Good afternoon. Today we're going to talk about cardiac imaging for patients with left ventricular assist device. I'm going to talk about cardiac CT role and what kind of finding you can expect in patients with suspected LVAD dysfunction. Apologize for my voice, I'm just recovering from a cold. Dr. Kassi will be here a little bit later. Her talk is probably the most important part, focus on echo and multimodality imaging integrated. So we've been imaging LVAD patient from early 2010, so we have quite some experience. Given the current LVAD we use is LVAD HARMATE 3, I took away all my slides. 90% of the non-HARMATE 3 slides I took out, and basically I'm going to focus on mostly HARMATE 3 patient. So when you look at a CT patient with LVAD, you need to focus on each part of the LVAD, but not only the LVAD, but also the surrounding structure and the connection with the cardiovascular system. So this is a picture of HARMATE 3. So difference from HARMATE 2, which is an intra-abdominal or intraperitoneal device, HARMATE 3 is implanted directly into the heart, as you can see here. It consists of inflow cannula, which suck the blood from the left ventricle into the magnetic pump. It's a continuous flow. So this is the pump. This is the inflow cannula. It's all made of titanium type of metal. And you have outflow cannula. And then you have a connector to the band relief. The outflow graft, we call it outflow graft, is actually a very thin, porous material. Sometimes outside the band relief, you can cover it with some type of Teflon type of material to prevent it from kinking, because this thing is going to go all the way up there to the ascending aorta. Okay, so we're going to look at the inflow cannula. Unfortunately, because of the blooming artifact, and we cannot see inside the pump. But fortunately, we know that the incidence of pump thrombosis in HARMATE 3 is extremely low. So basically, it's not okay that we don't see through it, but it's less of a problem compared to HARMATE 2, because now most of the abnormality, we can see it with the CT. Okay, so this is just an example of all three types of LVAD that has been used in our institution mostly. HARMATE 2 we did a lot of them. This is HARMATE 3, and this is hardware, which no longer being implanted. As you can see, that's what you see in the X-ray, and this is a corresponding MPR view and 3D volume rendering view of the device. So the inflow position, most of the inflow cannula position is almost never perfect, pointing toward the inflow, mitral inflow. It's always somewhere in between. Whether this is important or not, I don't know. We don't have the answer. As we're going to see a lot, we see a lot of things in the CT, but the clinical significance is poorly understood. Then you have this case, pointing toward the myocardium. This one pointing to the pump muscles and trabeculation. So this sometimes could be problematic because it could create suction event. But overall, the suction event that we used to see with the HARMATE 2 is not as common, but we still see once in a while. Okay, so this is just one of those extreme examples that we used to see with HARMATE 2. Essentially, the patient have VTAC and suction event, low flow alarm, VTAC, because you can see that thing is ramming to the interventricular septum, and that cause, depending on the position of the patient, will irritate directly the myocardium, causing VTAC. So this, fortunately, we don't see this almost anymore with HARMATE 3. Okay, so things that hasn't changed too much is outflow cannula. So things that we used to see with Harmony 2, we still see with Harmony 3. So this is a normal position you want to see. Go straight up, minimal distance between the left-hand side. This will be this is the outflow cannula connecting to the palm here. Straight shot all the way, perfect, nice, homogeneous contrast all along the aortic root. So this is a little bit kinking right there, which I don't think is a major problem, personally, because although it could cause a little bit of turbulence, but the degree of kinking is not bad. Then you have this kind of double kinking here, but none of them are significant. But this is probably significant. You can see it's almost like a slit-like narrowing here. So this patient could present with a low flow alarm. So this could be potentially clinically significant, but rarely they will act on this. Personally, I've rarely seen them going to the OR get explanted. They manage the pump setting and the patient overall does okay. You'd be surprised a patient with this sometimes could be quite asymptomatic. So one thing that we also want to look at is anastomosis side. So this is a normal anastomosis. So this is perfectly normal. This is a little where to do the suture. So this is not a narrowing. So this is unavoidable. Every single patient will have a little pledge right here. And this is, this could be a little problematic because this is about 1 centimeter. So you can see the area is about 1 centimeter square, a little bit more. Unfortunately, we don't see this almost, I never seen the cases of like this thrombosis that we used to see in Harmony 2. Thrombosis are both inflow and outflow cannula. This is just to give you an example of seeing what could look like. This obviously patient is very sick because has thrombosis of both inflow cannula and outflow cannula in a Harmony 2 patient. However, sometimes we can see this. I mean, I apologize, the image is a little bit dark, but you can see there's a little bit hypoattenuation material, mobile, and patient does have sign of embolic event. Again, what to do with this patient besides increasing the anticoagulation? We don't really know, but we still need to report this. Okay, this used to be a problem before 2018. There's been relief connection, and if you see this, because of the movement of the pump, sometimes this could be like this case. You could have very significant disconnection causing, again, significant obstruction. And that has been changed. The design has been changed, and they added a connector, and that problem is no longer an issue. We haven't seen it. So one thing that we see all the time is, I mean, if you look at the literature, they call it acellular fluid collection or biodebris, which I don't really favor. That's between the outflow graft and the vein relief. So this outflow graft is very, again, as I mentioned earlier, porous. So the fluid it's almost like exudates. And this could accumulate. Almost patient with sometime with the LVAD, they all have a little bit of ring hypoattenuation surrounding. What's interesting is almost never, most of the time could be homogeneous, meaning that all around. Sometimes it's eccentric. I mean, most of the time it's concentric. Does it change? It does. This is one of very few cases that we have repeat imaging showing that this actually increased in size, clearly, in 2 years. And I remember only 1 or 2 cases that reached this point. That this thing accumulates so much that actually causes narrowing. And there's quite a few literatures published already, people putting stent in this percutaneously to fix this stenosis. It's interesting because if you look at the Harmony 3 trial, I mean, this event is very low, it's like 0.5%. And kind of go with what we have. We have like 2 cases among over 150. But if you look at some European or other center, they have up to like almost 5%. I mean, I don't understand. Maybe I guess the implant technique varies so much that the report incidence. But again, this could be fixed, quote unquote, with percutaneous intervention, putting a stent. Okay, so we talk about inflow and outflow. How about the other area that we need to pay a lot of attention is the aortic root. So this is a patient who has stroke and find to have thrombus in the left sinus of Valsalva, as you can see. And this persists after delay imaging. With intense anticoagulation, you can see that things become more organized and become a little bit smaller. And this is important for us to know that not all this thrombus or clot that we see is permanent. Oftentimes, it goes away for good or bad. Like this case, patient has some GI bleed while positive stool. Could that be due to embolic event to the splenic artery system? We don't quite know. So if you have clot in the aortic root, obviously you can go to the coronary. So this is I'm going to present two cases, a very different clinical presentation. This is a patient, young patient, non-ischemic cardiomyopathy, presented with severe chest pain and troponin in the 70. And you can see the EKG right here. Some changes, but nothing dramatic. And if you see the echo, I know oftentimes we don't pay much attention, but I believe if you pay a little bit of attention, you can kind of suspect sometimes there's a clot, there's an echo density right here. And interestingly, the wall motion, I think RVE is depressed. Well, LV is very depressed. So, but he's supported with the LVAD. So instead of going to the cath lab, we got a CT. You can see the thrombosis of the right coronary sinus, and the clot extend all the way into the right coronary. See right here. I believe patient was managed with anticoagulations, and his symptom improved, and follow-up CT showed that the recanalization of that RCA thrombosis. So this will be a case of extension of aortic root thrombosis into the right coronary artery. And this is a patient with TIA, and the only thing we see here is no one defined what it is. I don't know what I call it sign of stasis in the aortic root. In the beginning, we don't really know what it is, but I told myself, I mean, this got to mean something, right? I mean, it's not normal to have stasis in the aortic root. And that's a main issue with the CT. We find a lot of stuff, like the debris, biodebris around the cannula. What does that mean clinically? So I talked to Dr. Chow, my fellow. I said, we got to find something to, collect this, our patients, to see how many patients have this type of sinustasis. So she came out with the idea of averaging the Hounsfield unit in the aortic root, in the sinus of Valsalva 03, and compared to the LVOT and the ascending aorta, where the cannula anastomose, and we correlate with a subsequent neurological event, and we found a very strong correlation, and it's been submitted under review for publication. So this thing, I think the future of what we do CT, we got to figure out what we see, what does it mean significant, what is the clinically significance, because potentially the next step will be find out why this phenomenon. I mean, it's kind of no-brainer. You think about it. If you have aortic stasis, you're going to have more stroke, technically. So the question is, what can we do to prevent stasis. Let the valve open. I don't know, but this thing is not, important thing is, I don't have the case here, but this thing is not irreversible, meaning this is transient. Some patient, these things could improve subsequently, so it's important because it could be modified. And this is another case of the patient has, amazingly, no symptom whatsoever. She had again, a non-ischemic cardiomyopathy patient, had complete thrombosis of the left main, and a clot in the aortic root. If you look at the old literature, most of the people say that the clot formed in the non-coronary cusp because there's no coronary there, so it's more prone to stasis. But we see it could happen anywhere. I mean, non-coronary cusp may be a little bit higher incidence, but as you can see here, I just show you 2 cases of coronary thrombosis. I mean, remember, this patient are all supported by LVAD, so they might have clinical sign of ischemia that could present a little bit more heart failure type of symptom. And one of the major things that Dr. Wu is very interested in is RV assessment. We all know very difficult to get RV function by echo. RVEF could be very easily obtained with contrast CT. We will talk about this in the LV function assessment. We can do Simpson method, we can do threshold method. And currently we are trying to validate RVEF and volume against cath lab data of RV failure. Again, I try to, to see what we found in the CT, does it make any difference in terms of managing the patient. And other type of complication, this is garden variety, patient could have tamponade. This is just, I kept this case because this extreme patient have LVAD. And you see the impressive tamponade and causing basically chamber collapse. And with the bending. This is one of the very first case we did with Jerry Easthaf. Now a couple of more interesting case, a complication could happen in anastomosis site of alpha graft. This is a patient with recurrent bleeding from the drive line. You can see there's a pseudoaneurysm and anastomosis site. Okay, invariably, this is all related to infection. And I think because this is a destination therapy and there's no plan for transplant, so patient end up having a percutaneous closure device to occlude that pseudoaneurysm to prevent more bleeding. So this is what it looks like. Basically, you cannot see anything anymore without this occluder device. And this is one of the most dramatic cases that we've seen. Patient actually, this is a young patient, but had recurrent infection of the eye and show up in his transplant in heart failure cardiology clinic with a pulsating mass in his, above his sternum. And you can see here, there's a huge mass between the sternum and the aorta. And when we hold, you can see, with gated CT, you can see the contrast. So it's a pseudoaneurysm, expanding pseudoaneurysm from an anastomosis site of the alpha cannula with the ascending aorta. So here's the contrast going through. Obviously, again, as I mentioned earlier, invariably this is related to infection, and we're fortunate to have Dr. Almala here, so I think PET imaging for infection FDG is one of the major indications. Any patient who has suspected LVAD infection, and I'm sure those fellows who have done and rotate with him have seen quite a few cases. Okay, just real quickly, scan protocol, it has to be gated, like the prior report with CT done with radiology, non-gated. I think it's essential that we do gated imaging, get much better image quality, we see better the aortic root, and the aortic valve sometime to look for aortic non-captation gap for AI. We tend to do retrospective gating. It has a little bit more radiation, but our transplant heart failure cardiology prefer that, so they can get some RV functions, and you get some of those stasis evaluation better. Contrast, we don't do patient with creatinine currents less than 45, and if it's really a young patient, sometimes we do spiral with a very low dose. And we have a small series showing that even with this patient, with contrast, usually it's very safe, and we haven't had anybody coming back with contrast-induced nephropathy yet. I recommend we read this guideline. This is the second rendition of this multimodality imaging sponsored by ASE, chaired by Dr. Esteve, who used to be in charge of the heart failure and transplant program here. And we're lucky to coordinate with Dr. Caravante and Dr. Muta. I think right now he's somewhere in the East Coast. So this just published last year. So overall, when do you want to order a CT? And when you suspect a thromboembolic event, you want to look at the aortic root. That's the first thing you go to. And then you go to the inflow cannula and outflow cannula. Very interestingly, we have not yet seen any cases patient with left atrial appendage thrombus. If you think this is high-risk patient, oftentimes of arrhythmia, sure, they are most of the time in anticoagulation, but not a single case of clear thrombus. Is that related to the suction of the pump and maybe increase the flow in the left atrium? I don't know. And left ventricle thrombus is a little bit harder to assess. You could potentially have some small layer clot, lodged between the myocardium and the inflow cannula. But if there's going to be clot, most of the time it's going to be aortic root. And obviously, troubleshooting the low flow alarm, you want to make sure there's no suction event, kinking, twisting, and patient with persistent heart failure symptom, you want to look out for RV failure, localized tamponade, aortic insufficiency, I put it there, mostly it's echo diagnosis. And also, I think important to exclude coronary event, such as coronary thrombosis, sometimes could give you heart failure symptom. And again, position-related VTAC, we almost don't see them anymore with HARMONY 3. And very importantly, in capital letter PET, CT for infection. It's very important because CT sometimes, the only sign we have could be a little bit air along the drive line, a little bit fluid, but in order for you to make the diagnosis, the PET is a must. Okay, thank you. That's all I have. Is Dr. Kassi here?
Question, please.
Yes, sir.
You may have to repeat it if there's on the mic. Thank you very much. Thank you, Sumin. Very nice cases. The question to you is, and we see that in the echo world, is at times the aortic valve in these VAD cases may barely open or may open 3 beats, every third beat or fourth beat. So the question to you is, have you seen any thrombus formation where there was some movement of the aortic valve? Or are all of them, the valve was completely closed?
I wrestle a lot with that question, right? We see this, I definitely seen cases, a patient with valve, not perfect opening, but that's open and have that stasis sign. So is that a kind of balance between the pump output and the patient's own output? I think I talked to Dr. Chow, and she's, I think, trying to convince Dr. Tan to help us to look for all the echo, to see if time, think about time, we can go back and look at the echo to see how many, if the patient most of the time have the valve closed or intermittent opening, is that predictive of stasis, clot? Issue is not very common. I think out of almost 100 cases that we review, I think we have about 6 or 7 root thrombosis, clear root thrombosis, and about maybe 30 has this stasis sign. So I think that will be a very important question. We can show that we can link that less time of aortic valve opening lead to most higher chance of having aortic root stasis, because that's something they can do, right? Change the pump output. Yeah. So next step will be understand. All right. So Dr. Kassi is not here yet. We'll show you some more cases. Okay. Another thing that, again, we see a lot of things. Dr. Guha is personally very interested in this. There is a constriction here. I mean, that RV is fixed. Important. I think that the question here is, how do you measure this? How do you quantify this? And not common, but it does happen. You can see the septal bounds, but again, okay, the artifact is challenge, and we do have some help. Again, this is the thing that some work we did with HARMONY 2. We haven't repeated with HARMONY 3 yet, but the metal reduction artifact that Siemens has does help with the image quality. This is just, I think this is more belong to the museum. Patient with, we have a couple cases since I work here, have total artificial heart, syncardia. So, now over time you're gonna see 4 artificial valve, prosthetic valve in same patient. Let's see. This patient show up with, again, the case of tamponade, localized tamponade over the PA. And you can see everything was working fine, but if you have tamponade, the patient's gonna be in heart failure symptom. And post-op, it looks much better. And just wanna show you guys how all the 4 valves working. So this is a Medtronic hole. I don't think we use this valve. I don't think anyone implant this valve anymore. You can see the opening angle is perfectly preserved. Again, and this is actually external air pump. The squeeze of blood. Again, this belongs to the museum. All right. Okay, again, a lot of case series, okay? A lot of bunch of cases together and not much clinical utility. I think that's the main challenge. And main challenge is we really need multi-center study registry, and Mawaj should be commended of spearheading this. I think she's had tried to work with people in MedStar, Henry Ford, Texas Heart, because you do need cases if you want to have clinical correlation between your CT finding. So again, so this is one of the first things I did when I came back here in 2007, Jerry encouragement and providing patience, and we show overall if you use it carefully, our first experience is quite safe, and we carefully document the hemodynamic reaction to contrast, because contrast it is could depress LV functions, and the renal function overall. Again, the first serious patient is very stable. This is, again, historical interest. Inflow cannula position, I think, less an issue. And my wife also still work. I think this is really interesting and important to understand the aortic root thrombosis. If we could prove it in a multi-center registry that is really linked to development of acute neurological event, I think computational fluid dynamics will help us understand the underlying reason why this happened. Okay. All right. Yes.
Is there any way to quantify the location of the LVAD count relative to the spectrum? Is there any about that?
Yes, there's some theory that if inflow cannula is pointed or affect the septum, that could interfere with the RV function as well. Dr. Kassi, when she was a fellow, this is actually what she did. She went to the lab and measured all the angles. You could argue that this, even this has no clear suction. You could argue that this pointing to the septum could affect the RV function. Yeah, well, that's definitely, absolutely. I think if you could show that the RV function deteriorated over time and correlate with the position of the inflow cannula, yeah. It's up to you to find out what parameter, just like what Dr. Chow did with the aortic root stasis. She come out with she went run the analysis. Obviously, it's retrospective, need to be validated, but any interesting concept. We're scanning the patient. We get so much information. Will be very helpful to help if we can find any clinical correlation, because pretty much like any surgical technique, surgeon does what they think the best, right? Unless you prove them with some data that, maybe this type of position is not as good, but sometimes it's hard to modify it, because when the chest is open, they plug it in where they can. It's not they can have an intra-op CT and find out where the position is. So, but yes. So any fellow who's interested in research, we have a lot of data. All right?